Welcome, everyone, to Retina Synthesis. I'm Dr. Carmen Poliafito. I'm here today with Dr. Jay Duker, a good friend and colleague. Dr. Duker is currently CEO and president of Eyepoint Pharmaceuticals and is also adjunct professor of ophthalmology at the Tufts University School of Medicine. Jay, welcome back to Retina Synthesis.
Yeah, Carmen, it's great to be back and really great to see you again. Obviously, your listeners may not know this, but you and I go way back. And I owe a lot of where I am today to your good guidance.
So terrific. The TKI revolution is approaching in the retina space. Why is the TKI category so important to retina specialists?
So yeah, it's really interesting to Carmen to think about the way we treat chronic diseases like wet age-related macular degeneration and diabetic macular edema. Most chronic diseases are first of all treated with a multi-MOA approach. And I can still recall almost over 15 years ago, Larry Singerman at a meeting saying, look, wet AMD, it's going to be like cancer. We're going to have multiple MOAs and we're going to hit it in multiple places. And we all believed that was going to be true right away. And yet here we are almost 20 years later with perhaps one drug that has multiple MOAs. And so the idea of treating a chronic disease with multiple MOAs is, we're used to that. We treat, glaucoma with multiple drops. We haven't really been able to have that in retina. The second thing is we're treating a chronic disease with essentially acute therapy. And while the acute therapies we have, the anti-VEGF ligand blockers are terrific with efficacy and very good with safety. And we've managed to really become very efficient in our practice in using them. The big problem is really in the long term. We're not getting the visual results that we feel we should. And it's not for lack of trying. It's very hard for patients, practitioners, the whole system to be able to treat patients who need monthly, bi-monthly, or even every 3 months on a regular basis for years and years. Fatigue is a factor, patient fatigue, doctor fatigue, and the fact that we are just so busy. So the big unmet need in those two diseases, wet AMD and DME, is sustained release. It's very hard for a protein to exist at body temperature for a long period of time without breaking down. And of course, we do have an approved sustained release device, the port delivery system. But in order to really look for solid, good, sustained release, a small molecule fits the bill. And the tyrosine kinase inhibitors are small molecules. Now, if you just use a small molecule and inject it into the eye, it's going to be gone in hours or days. So you need, in order to use it, you need some type of matrix to keep it from going away rapidly. What the TKAs offer is a new MOA. They work at the receptor level, not soaking up excess, ligand with a ligand blocker, but rather at the receptor level within the cell. So you put the insert into the eye, it releases the small molecule crosses the retina, gets into the cells, and blocks the effect of VEGF. And it blocks all isoforms of VEGF. And for example, the TKI that we're using at Eyepoint called vorolanib has activity against all three of the VEGF receptors. It also has activity against PDGF, which theoretically should result in less fibrosis. And now recent data suggests we actually also block an inflammatory pathway. We have activity against the JAK1 receptor and IL-6, which has become a very hot topic and a hot pathway in retina. IL-6 works through the JAK1 receptor. So by blocking the JAK1 receptor, we should also have an anti-inflammatory effect. So we have a multiple pathway TKI here with vorolanib. And vorolanib also for us was a logical drug to use your listeners may not know this, but vorolanib was actually studied as an oral agent in wet AMD many years ago. At the time, it was called X82, and it went through phase 2 trials. And while it had good efficacy, like all the systemic TKIs, there were systemic side effects, hepatobiliary side effects. So it never got out of phase 2, but it didn't have any ocular side effects. And of course, in the studies we've done, we've seen no safety signals with our inserts or with the drug. But we were able to license vorolanib, and it was able to be put into our Duracert technology, which now has advanced. Again, Duracert, the basic technology, has been around for decades. The original gancycler implant, which I think, the second person ever to put one in the eye, was based around the same type of technology. But what our scientists have been able to do is make these inserts bioerodible. And because they're bioerodible, we're able to, again, deliver them multiple times over and over, because we believe in patients, our inserts should last at least 6 months at therapeutic levels and deliver drug at therapeutic levels until approximately 9 months, at which case the drug should be gone. And the interesting part is now we're able to make these inserts so they're 94% drug, which is really an achievement. When you look at inserts or ocular inserts, typically they're 50–60% drug, but we're now 94% drug, only 6% matrix, which makes it, again, very advantageous for use in the eye. So to summarize, TKIs are small molecules and they can be sustained release. And that's really the unmet need that we're looking for, the ability to control the disease both anatomically and visually with fewer injections and fewer visits.
So tell us about your neovascular AMD program from the beginning to where we are today.
Sure. So what's interesting, again, and I'm very proud of this, and is that the execution at Eyepoint has been terrific. I joined full time about 4.5 years ago, right around the time that we dosed our first patient with DURAVYU in the phase 1 wet AMD trial, which is called the DAVIO trial. So we're here, a little over 4.5 years later, and we've completed 4 trials, 1 phase 1, 3 phase 2, and we're now fully enrolled in 2 wet AMD phase 3 programs and about to start 2 DME programs. So the first trial, DAVIO, or DAVIO 1 it was called, and the name was derived from Duracert and Duracert and vorolanib in ophthalmology. That's how we came up with that acronym. So we enrolled 17 patients. We had an ascending dose, no control, and the patients generally did well. I mean, we had a couple of patients in the trial who were really tough to treat. And we had one patient in particular that I recall that was on monthly injections, and the monthly injections weren't working at all. This patient had a lot of fluid, and every 4 weeks had the same amount of fluid. Put a Duracert in, and the patient responded, not perfectly, but every other month they were completely dry. And so we were able to extend this patient from monthly injections to every other month, which, again, for real world is a terrific result. And that's one thing that I'd like to stress, is that as retina specialists, we're used to a company saying, okay, we got a new drug. It's better than your old one. Just toss away your old one and use us. And that's not how we're approaching this. If our data holds in our phase 2 data from the DAVIO 2 trial, which enrolled about 160 patients and did have on-label 2 milligram Eylea control, if that data holds, you should be able to control maybe 2/3 of your wet AMD patients with our injection alone. But I think some doctors will want to take advantage of the 2 MOAs. And the idea of maybe alternating a ligand blocker with a TKI is something that doctors may really like. And if you look at the results of our phase 2 wet AMD trial, about 90% of the patients in that trial in the 6 months after our drug went in had either 0 or 1 supplemental injection. So if you extrapolate that and say if that's true in your pivotal trials and also true in the real world, that you can control 90% of wet AMD patients with 4 injections a year or less, that's a terrific result. And that will lead to, again, I think a lot of uptake for our drug. So we did the phase 1, we did a wet AMD phase 2. We were non-inferior to on-label Eylea. Uh, and the change in visual acuity at the primary endpoint at month 8 was statistically identical. One of the arms of our drug had, I think, was zero point 0.3 letters difference, and the other one was 0.4 letters difference. Very small, essentially statistically identical. And we've had great safety, and obviously, I don't need to tell this group that safety in retina is critical. So we've dosed over 190 patients in 4 trials through phase 2, and we've had no ocular or systemic SAEs due to our drug, due to the insert, due to the injection. We've also had no safety signals, and so that's really, obviously, really important. And I can add, in our phase 3 that's ongoing, we've enrolled over 900 patients in 2 trials. They're called the Lugano and the Lucia trials. Those trials, we look at the safety, the masked safety, and what we're seeing is similar safety to what we've seen in the other trials. So nothing worrisome, no safety signals, and so that so far, I would say the masked safety data looks good. So what we're hoping to find in wet AMD is that we are statistically non-inferior to on-label 2 milligram Eylea. When we're dosed every 6 months after the load, and they're dosed, obviously, every 2 months after the load. So that would result in a reduction in treatment burden, which we'd like to show. And if we're non-inferior, I think that in and of itself would cause quite a bit of adoption of our drug. On the other hand, we may be superior because of this IL-6 pathway that we're also blocking. There are studies that show that the eyes that do the worst with wet AMD have the highest level of IL-6. And it's certainly conceivable that this blockage of the inflammatory pathway may deliver even better results, which would cause our patients to do, obviously, even better with fewer injections, which would be a bit of a holy grail. We also did a phase 2 diabetic macular edema trial called the Verona trial, and that randomized patients to Eylea versus 2 doses of our drug. And the primary endpoint of that study was not visual acuity; it was time to first rescue, which again we showed more longevity than a single dose of Eylea, not necessarily a hard bar to get over. But we showed, interestingly, at week 4 in these DME patients, all of whom were active, all of whom were wet, that with our drug alone, compared to Eylea at week 4, we were already about 4 letters superior. Both arms showed that. And we were already about 40 microns drier. Now, in the end, if you say, okay, suppose you end up non-inferior to on-label Eylea, great. But if we do it with fewer injections and we're better as early as week 4, I think our adoption will be wide, because what patient wouldn't want to get better faster? And if we can do it with fewer injections, it's an added bonus. And that's, again, we believe that's evidence of the inflammatory pathway. It's not just blocking VEGF. So we've got 2 phase 3 DME trials that we've initiated. They're called Como and Capri. They will each enroll about 240 patients. It's 2.7 milligrams of Duravyu against on-label Eylea control. We're going to dose the first patients in the first quarter of next year. And based on how rapidly we enrolled the wet AMD trials, I should say that each of those trials enrolled well over 400 patients in about 7 months, which is really, really rapid enrollment. But we think we're going to be able to do similar enrollment for the DME trials. We're enrolling fewer patients. So looking forward to next year, we're going to have top-line data from the first wet AMD trial sometime in the middle of the summer, with top-line data from the second wet AMD trial sometime several months later. And then we should be announcing full enrollment of the DME trials around the same time, which puts us into top line of the DME trials at the end of 2027. So we're really gearing up for an exciting next year at Eyepoint.
Very exciting. What's the study design for the DME trial?
So it's simple. So we are enrolling both previously treated and naive DME patients. It'll be about a 75-25 ratio, naive to previously treated. And that's pretty much standard now. The more recent trials did have a mix of both naive and previously treated. Patients will be randomized to either on-label Eylea control, which is 5 monthly injections, and then every other month after that, or 2.7 milligrams of Duravyu, which they'll get on day 1, along with an Eylea injection. And then that arm, the Duravyu arm, will get 2 more Eylea shots at week 4 and week 8. And then the patients will come in monthly. Duravyu will be redosed again at month 6. The primary endpoint is a blend of the change in visual acuity, non-inferiority to Eylea at a blend of weeks 52 and week 56. And the FDA has granted us a non-inferiority margin of minus 4.5 letters. They will be 2-year studies, both wet AMD and DME, in order to get full label for re-injection every 6 months. The FDA wants to see a minimum of 300 patients dosed at your go-to-market dose with your go-to-market interval for 2 years for safety. And so we will be showing that in both wet AMD and DME trials to get that on the label. But we'll be able to submit the NDA after 1 year for both wet AMD and DME. DME will be submitted as an sNDA, and hopefully by the time we submit, we will hopefully be approved in wet AMD if everything goes well.
Well, it's an exciting schedule going forward.
It is.
And congratulations on the good results so far.
Thanks.
We will be stay tuned for the results of the clinical trials.
Can't wait.